when I think about how patients perceive care, they expect, like, I think about McDonald's, they want that same consistent process every time that they can expect from your health system. And so we're working to align with Meditech and technology, as well as aligning our teams there. And so, in my opinion, we're not doing our diligence if a patient shows up at the point of service and they're just now finding out that they owe, some money for an estimate, they have some forms they have to sign, if there's an ABN or something, anything like that, the patient's finding out at the point of service is just bad patient care, bad patient experience, in my opinion. We need to be doing everything pre-service as much as possible. All the time say shift left, some of my pull string phrases. But we need to really focus on doing everything pre-service as much as possible. One, because the patient deserves that. And it's funny to me to think that healthcare is the last industry to finally jump on the bandwagon and understand that patients are consumers. And not everyone wants to go out and get an estimate, things like that, but many do more often than not. So we're trying to make sure that we're engaging patients with their responsibility pre-service so that they're aware of that. We're collecting pre-service as much as possible. The perception is that older patients do not engage in technology, things like that, and that's just not true. If you look at the data, older patients do in fact engage just as much as, millennials and things of that nature. And so I think that sometimes we hold ourselves back in what we might allow our patients to use, or having omnichannel opportunities to engage our patients, because we might feel our patient population isn't ready. And I sold this types of solutions to help front end and patient experience in my previous life to places that have horse and buggy parking in the parking lot, so very rural areas are using this type of thing, and it does help to engage our patients and to increase their satisfaction.
And we've also recently, following along pilot, we're using Clear, the same technology that you can use in the airport for bioidentification for e-check-in. So over the next year, we'll be rolling that out across the entire system.
There is also a fear around AI and automation in replacing our team members. So I've been at the lake since January, and when I came here, I started talking about how I wanted to roll out all these solutions on the front end that I previously spoke about so that we could help us to manage and measure the issues that we had. And when I shared that I would like our patients to engage and have self-service options, a team member who was actually on this call, she spoke up and she said, hey, if we're getting all this automation, what does this mean for my job? What happens to me? And I just looked around at the whole team and said, has there ever been a day in patient access where we didn't have something to do? Has anybody bored, or there's a lack of work around here? And everybody started laughing, right? So the point is that you remove the tedious tasks that we all know are the things that cause our denials every day. You can build out good products by looking at your historical data, 837s, 835, specific to your organization. Those things will help you to understand your trends and the things that you really need to focus on.
So we have an internal RPA team here at Mass General Brigham that reports up through our digital functionality. And what I've been trying to do is look at, like Alicia mentioned, repetitive tasks that you don't necessarily need a human to do. And what we'll do here internally is build bots to do some of that work. One of our biggest issues with referrals, as I'm sure many of other organizations have, is that the primary care physician that we have on file at our organization in the registration does not match what the insurance has on file. So when the patient has an HMO, they have a different one listed. So we were actually using a person to either message the patient or call out, and we've been able to automate all of those messages. And then that allows the patient either to message us back, if they've updated it, or if they have questions, they could certainly call us. And then if they don't, we're actually moving that function over to an auto dialer. So that's been freeing up, 2 people that have been doing this all day.
We've got a few bots running for payer eligibility inquiries, like our Medicaid. We are working with the vendor on AI for our automation of our auth initiation and some statusing. So we're excited to take some of those, mundane items and allow the staff to do more complex tasks.
Agree with Alicia. It's just something I had recently heard as we're looking at our ASA table in Epic. is that, you can't aspire to have the jet if you're currently in a horse and buggy. Let's go to the car first.
Driving the
So-
Pinto, got to start with the Pinto, get up to the caddy.
Exactly.
Yes.
And Donna, that's some of the things Alicia mentioned, like making sure you have a clean payer table. That's really where we are getting ready for this automation for the prior auth, is making sure the house is clean, so to speak. And to having the QA analyst and educators, that is so critical to an efficient operation.
I would say, just like going back to what I said about when you're choosing any AI or a partner, just really ensuring what it is that you're getting. Like, do not hesitate to ask questions, poke holes, like, hey, what is that word? Is it the same thing as this? Because we all know all the acronyms in healthcare are convoluted as it is. But then when you get talking about tech and solutions, there's all sorts of words and buzzwords out there. So ask directly, what is my intended outcome here? Like, show me what that looks like, or how are we getting to that? What data are you leveraging? Like, you're typically going to use 837s, 835s, like 12 months of historical data will show a good sample size for your organization to see the behavior specific to you all. Your charge master, payer contracts, things like that. Just looking at those things to make sure that they're up to date, and how can you leverage those things to help you to power automation. And then you love it. And if you love helping people, I mean, for me, it fills me up just to help people every day, and knowing that even if we move it 1 inch every day or a centimeter, that we're making healthcare better, then I'm happy and I've been successful. So I also don't want the industry to continue to say that patient access is an entry-level position. Like, we have to build that structure so that people can see a path forward, because we need the future VPs of patient access and revenue cycle, CFOs, so on and so forth. I mean, it's just so important that we make sure that we're focusing on that.
What we've asked the front end and registration to do has grown so much. It's no longer a name, date of birth, and let me, take a copy of your insurance card.
You're right.
One of the more challenging in the whole rev cycle, we're the front of the rev cycle. And I read somewhere recently, 70% of what happens in the rev cycle occurs in patient access.